Urinary incontinence and other pelvic floor disorders affect 1 out of 4 women. I'm pleased to have Dr. Drew Cassidenti here to explain the causes and treatment for this growing problem. He's a urogynecologist in Orange, California, and the director of the Female Pelvic Medicine and Reconstructive Surgery Program. Thanks for coming, Drew.
Thanks for having me, Larry.
So, I think most people know that the pelvis is somewhere below the neck, but what exactly is the pelvic floor? I don't think people are that familiar with that term.
Yeah, the pelvic floor basically are the muscles and connective tissue that actually support the rectum, the vagina, the uterus, and then the bladder. So it performs, it's a cradle of muscles. They're called the levator ani. And with the muscles, there's connective tissue to also support the rectum, the uterus, and the bladder.
So when this malfunctions in some way, the common problems are, what would they be?
Common problems with pelvic floor dysfunction usually are urinary incontinence or bowel incontinence, loss of control of feces or gas, as well as pelvic organ prolapse. The bladder will prolapse, the rectum will prolapse, or the uterus will prolapse, and women will feel pelvic heaviness. They'll feel like they're sitting on a ball. They'll feel vaginal pressure. They'll sometimes have obstructive voiding if their bladder is prolapsed. They're kinking their urethra because their bladder is so low, and they have obstructive voiding. They have to double void. They'll void and feel like they're not done. Those are the most common issues.
So when you say prolapse, the organs are actually falling within the vagina, is that what you mean?
Correct. The bladder sits on top of the anterior vaginal wall. So you have the vagina, and then the bladder sits on top, and then the rectum is below. So the bladder is supported by a hammock of connective tissue and smooth muscle. And the most common injury that causes prolapse is childbirth. When babies come out of the vagina, they stretch and tear this support tissue. And then as women get older, the tissue weakens and then fails. So the bladder will prolapse down into the vagina and sometimes out. The rectum will prolapse up into the vagina and then sometimes out. Sometimes women will feel stool getting caught during defecation. Some women actually have to put their fingers inside the vagina and push down to get stool out. That's called a rectocele. Bladder coming down is called a cystocele. And then the uterus will also prolapse as well, and that's called uterine prolapse.
So let's talk about urinary incontinence. Is that the most common of all these, or is the prolapse just
urinary
as common?
Urinary incontinence is more common than prolapse. It's very, very common. 50% of women over the age of 50 have some sort of urinary incontinence.
Holy mackerel, 50%.
Correct.
That's amazing. So are there different types of urinary incontinence, or that different causes or different types?
There are the two most common types of urinary incontinence. First is stress incontinence. Stress incontinence is when women lose urine with cough, sneeze, strain, hitting a golf ball, picking up a grandchild. Anything that causes stress, raises intra-abdominal pressure, is stress incontinence. I use my hand as a model to explain that. If this is their urethra, which is the opening to the bladder, and this is their bladder, so their bladder stores urine, and then they urinate through the tube, which is the urethra. Before they have babies, they have good support underneath their mid-urethra. So when they cough or sneeze, they have sudden increased intra-abdominal pressure that pushes the bladder down. If they have support here, when they cough or sneeze, their urethra compresses and they don't leak urine. During childbirth, when babies come out, they stretch and tear this tissue, and over time it weakens and they lose this support. And then when they cough, there's no support here, their bladder drops and urine spurts out. And that's called stress incontinence, and how we best fix that is to re-support the mid-urethra with a sling, which is a support tissue of a mechanism to give a backstop for the urethra to compress against. That's stress incontinence. The other most common type, or the other common type, is called urgency incontinence. Urgency incontinence is where women will suddenly get the urge to go. They're driving home, they pull into the driveway, they put the key in the door, and all of a sudden they have this incredible urge to go, and they can't suppress their bladder and get to their restroom in time, and they have a large leak. That's caused by a bladder muscle spasm. The bladder is made of muscle, and if it spasms prematurely, then they'll have a large leak of urine. That's usually treated with medication to relax the bladder.
So you are a urogynecological surgeon, so this is a unique type of training beyond somebody who does OBGYN, or?
Yeah, urogynecology is someone who's done 4 years of medical school, then 4 years of residency in obstetrics and gynecology, and then if you do a fellowship, as I've done, it's a 3-year fellowship in urogynecology, female pelvic medicine, and reconstructive surgery. So it's 3 additional years of training after residency and pelvic floor problems.
So I guess with the one type of incontinence you can treat surgically, and the other type you treat medically, right?
Yeah, stress incontinence is usually treated. Exercises can help both, and we usually start with exercises, Kegel exercises.
Kegel? Okay.
And for stress incontinence, if Kegels don't help enough, then we'll do commonly what's called a mid-urethral sling, and I actually brought one here. And what a mid-urethral sling, again, we need to support the urethra. We just need a hammock here so the urethra can compress.
And the urethra is the little tube from the bladder to the outside.
The urethra, yeah, you have your bladder that stores your urine, and then when you urinate, the small tube that the urine comes out into the toilet is called the urethra. So the urethra is the very opening of the bladder. So for stress incontinence, where we have to re-hammock and re-support the mid-urethra so you don't leak when you cough or sneeze or laugh, we do a sling. And a new technology now is this minimally invasive sling. It's a piece of polypropylene. The patient's body's tissue will grow into this, but this performs the permanent hammock to support the mid-urethra. And we now have what's called the single incision sling, where it's a small incision just underneath the urethra, and we use an instrument like this to basically feed the sling into the pelvic sidewall muscles, and then this will form a permanent hammock to support the urethra. And so that's now a 20-minute sling.
So how would that go? That would go like this?
Yeah, basically, yeah, if you point your finger at me, if that's the urethra, we're now hammocking the urethra with this sling. Okay. So this supports the urethra now. Okay. And that's a sling procedure.
So, and this is done in the hospital, in the office?
Outpatient. Outpatient surgery.
So they come in, they go home with the same day?
They go home within an hour.
Wow. Yeah. And how long does that take?
That takes me about 10 minutes.
Wow, that's pretty cool. And that could give them long-term permanent relief?
The success of mid-urethral slings for stress incontinence, if you define success as women are improved 90% or better, the success is 90%. It's hard to make them completely dry. Mm-hmm. If you make the sling too tight to try to make them completely dry, you then run into other issues like urgency. The urethra can get irritated from sling tension. So there's a real art to sling tension, and the goal is to maximize the stress incontinence success, but not make it too tight.
So for something that can really affect their life adversely, a 10-minute procedure in the right hands can really change the quality of their life dramatically.
Absolutely, absolutely. A lot of women live with incontinence, and they shouldn't. I mean, it's an embarrassing topic. Yeah. A lot of women, you're not going to talk to other friends usually about your incontinence. A lot of women know their moms had problems, and a lot of women assume it's a normal part of aging. It's not a normal part of aging, and this is something we can help them with.
And what is this right here?
Prolapse is another common problem that I deal with, and that's again when we talked earlier where the bladder will prolapse down, the rectum will prolapse up. One of the new technologies we have now are to do what's called a graft augmentation. So to re-support the bladder and give greater durability, we now use different types of lightweight meshes, and this is what it looks like. And basically the body will just grow into this mesh, but this forms a permanent hammock to re-support the bladder, and this is the most durable repair we have now.
And that must be a longer procedure. How long does that take?
Well, to do a formal bladder support with mesh is about 45 minutes to an hour.
45 minutes. And they go home the same day?
Overnight. Most women stay overnight with this. Yeah. Overnight, they go home the next day. But commonly, they need this, they need a rectocele repair, and they need a sling. So commonly, all three things are being done. And then if all three things are being done, it's about an hour and a half, 2-hour surgery, and they spend one night in the hospital. If it's just the sling for incontinence, that's outpatient, and they go home.
And so this is like really life-altering for a lot of women, I would imagine. Geez.
It can. It's very rewarding. A lot of women, they tell me I gave them their life back. Yeah. It's interesting because a lot of women slowly give up things they like to do because of incontinence or worry about leaking urine or feces. And they give up golf, they give up dancing, they give up going to shopping, and they slowly make changes. And when they get their control back, they realize they had made a lot of sacrifices unnecessarily for a long period of time. So it's actually been very sad. I get a lot of hugs for thank you for giving my life back, and it's been very rewarding. It's been very satisfying.
That's fantastic. We're just about out of time. So I guess the message is this is an embarrassing topic, but it's something that can be taken care of. They go to the right physician like you, and they can get their life back.
Absolutely.
Great discussion. Thank you so much for coming. I learned a lot, and I know our audience did too.
Oh, thank you, Larry. Thank you for having me. That was good. Yeah, that was good.